Yeah, you said Rituxan is being restudied under, I think, a different name.
It's a copycat drug. It's a slightly modified molecule. So the question is Rituxan being restudied? The answer is yes.
So what phase are they in with that?
They're just starting phase 3. So at our center, we have a study for patients with relapsing forms of MS, including secondary progressive, and we have a study for primary progressive MS with ocrelizumab. These are phase 3 trials. The study in the relapsing forms will be comparison against Rebif. Rebif is the active comparator trial, so we want to beat Rebif for the study. For the primary progressive, it's a placebo-controlled study, and that's because it's mandated by the FDA and the EMEA, which is the European equivalent of the FDA.
And what's it called?
It's called ocrelizumab, which is OCREALIZUMAB. I actually participated in spelling bee when I was in high school.
Is that being studied for older patients too?
The question is the ocrelizumab being studied for older patients? I don't honestly know what the age cutoff is. It's at least 55, it may be 65.
Is that trial still open?
Yes, it is. They're both open. They'll probably be open for the next year. They're big studies. There's 250 centers involved. They're big studies.
No chance of getting Genentech to take those and bring them out to the FDA?
Genentech, the question is there any chance of getting Genentech to bring them out? Ocrelizumab is being developed for the FDA for approval, as well as ofatumumab and a couple of other anti-CD20s. So there's 3 companies that I'm aware of that are in clinical trials with anti-CD20s. So we're not the only ones who think that they're valuable. People are investing a lot of money in this class of drugs. There's no chance the FDA is going to consider rituximab, and the reason is they have no mechanism. They don't care. That's not their job to look at off-label use in this case. So if society wants to use it, society can bring pressure to bear on insurance companies to cover it. So for example, Cytoxan or cyclophosphamide is an old chemotherapy. It was never approved by the FDA for MS, but it is covered by insurance companies, and that was because a patient in California sued Blue Cross Blue Shield and won about $1 million about 20 years ago. And so the insurance companies, it's a business decision. You lose money in the court, you lose money by covering the patients. And rituximab, I think we can make a good argument to them. They would save money, and the data would suggest that for certain patients, it's just as effective as any of the FDA-approved drugs. And there's less safety monitoring. All we do is see you once every 3 to 6 months when we do a B-cell test. We don't have to do all the other things we do for Gilenya, for example. You had a question?
I was just going to say, with interferons, another issue, isn't it the development of antibodies?
Yes, that's a very good point. So the question with interferons is that there's another issue, and I meant to bring that up. One of the problems with some of the newer drugs is the possibility the patient will develop a resistance to the drug. The main mechanism in MS for that is that patients will actually identify the drug as a foreign substance and develop an immune response to eradicate it, just like they would an infectious agent. And with the interferons, that is a problem. And with Avonex, it's about an 8 to 12%, 8 to 15% incidence of neutralizing antibodies. With the higher dose formulations, it's somewhere between 25 and 35%. In Europe, it's mandated by a consensus statement that if you're on interferons, they do that blood test every year, and if you're positive, they take you off interferon. And that's because in the studies where we had the power to see effect, in other words, where there were enough patients where you could actually do the statistic on them, we always saw a loss of treatment effect. So there are examples in published studies where they didn't see a loss of efficacy, but if you look at them, it's a small number of patients, and it's a power problem. And from a statistical standpoint, you have to have a certain number of events to have a chance to distinguish that between chance. And they just didn't have enough patients in the study to do that. So that's called a type 2 error, where there really was an effect, but you didn't see it. And that's often not discussed, and it's calculable. You can calculate the type 2 error size of any study. And they really should, because in those studies, the type 2 error size was as large as between 40 to 80%. In other words, they had no chance of actually seeing an effect. So in the United States, if I treat with interferons, I do the neutralizing antibody assay every year. And I would urge that if you're on it, particularly if you don't have much in the way of side effects from it, it'd be reasonable to test that. Because if it's positive, your treatment effect is somewhere between 0 and about 5 to 10%. And there's much better therapies for $30,000 a year.
What's
Yes.
the test? I'm sorry, you're talking about.
It's called a interferon neutralizing antibody test. I think there's more than one company that provides it. The only company I know of is a company called Athena Diagnostics in Massachusetts, and the problem with it is very expensive. It's $1,000. They're gouging you, but this is America, and that's perfectly legal. So that's one of the problems in America is that there's been reluctance to adopt it because it is such an expensive test. But the test could be developed by any of the other laboratories and offer a more reasonable price. But I still think that when you're spending $30,000 a year, plus it's your future that you're talking about, it's an appropriate thing to do based on the scientific literature. So it's a good point. Yes, sir.
How long can you be medicated on Tysabri after 2 years max? Is there a maximum?
So the question is, how long can you be medicated with Tysabri? There actually is no limit, but but it's a kind of a complex issue. So the PML is the major problem with Tysabri by far. If it weren't for that, I think everybody would be on Tysabri right now. The risk of PML in patients who are antibody negative for the virus so far is 0, but we would tell you it's about 1 in 30,000 based on the false negative rate. So in those patients, when we follow them long term, and there's about 14,000 patients that have been on the drug for 4 years or longer, and we don't really see any other serious adverse events occurring out there. So far, I do not know of any data in the world that says that there's some problem that develops with Tysabri the longer that you're on it, with the exception of PML. And in the case of PML, there's been no cases in the first 12 months of treatment. In the second 12 months of treatment from year 1 to year 2, the risk is about 1 in 3,000. The risk in year 3 is about 1 in 700. If you've been treated with chemotherapy, such as Novantrone, Cytoxan, azathioprine, methotrexate, then your risk is as high as 1 in 150 in year 3. So that's where the 2-year rule comes in. So we feel that right now, based on the FDA approval and based on the alternatives right now, that for patients that are antibody positive for the virus, that the drug is still useful for patients with more aggressive disease for about 18 to 24 months. Then we think the risk is such that it's probably reasonable to switch to something else. So that's where the 2-year concept comes in. Now that Gilenya is in the marketplace, we don't really know whether it's safer than Tysabri for those patients who have not been treated with chemotherapy but are JC antibody positive. We don't have enough data yet, so we don't know. So right now the tendency is for us to put people on Gilenya because it's unknown. Tysabri, we have a known risk. We know it's about 1 in 700 if you've not been treated with chemotherapy.
So, yes, after Tysabri, after you get through the 18, 24 months, what do you typically do then, and how long before you can go back on Tysabri and be down to the 0 risk for the first year?
So it's kind of a question, complex question is, if you've been on Tysabri, the question, if you've been on Tysabri for 18 months or roughly, what do you go to then? And how long do you have to be off Tysabri before you can go back on and have the risk of PML back to 0? The answer to the second question is we don't know. There were a large number of studies started to answer that question. They were all stopped because of an unexpected problem, and that is that Tysabri blocks the ability of immune cells to get in the brain, but it doesn't kill anything. So the cells that actually can drive MS, that cause MS, are still in your system. They just can't get into the brain. And what happened in the studies was that when they stopped the Tysabri to begin to monitor patients off the drug, they found that they had a burst of MS activity that was actually remarkably severe that occurred about 2 to 4 months after the last dose of Tysabri, which is about the time Tysabri completely leaves the system and the immune system goes back to normal. And there were four studies from different centers from different parts of the world saw exactly the same thing. We see it in clinic, and it's been published at the American Academy of Neurology at least a half a dozen times. So we call it IRIS, or I call it natalizumab withdrawal syndrome. And it's not just MS. It's inflammation like MS, but it's much more. So in patients that have this natalizumab withdrawal syndrome, they often have 20 or 30 or 40 active lesions in their brain at about month 3. It peaks at about month 3, then it goes down. So that's one problem. Now turns out it's pretty easy to prevent. You can do it by just giving a dose of steroids once a month for the 3 months, or putting people on Copaxone before you stop the Tysabri, probably with interferons. So it seems to be easy to prevent as long as you anticipate it. If you wait till it happens, though, it's very hard to shut off. And Dr. Bruce Cree from UCSF, in his study, showed that the average increase in disability was over a point, 1.4 points on the EDSS scale. That's a big change. That takes somebody from working to not working. So for us, it's a serious issue. The company, Biogen, just published a paper saying they went back and looked at their data when the drug was withdrawn from the market, when the first cases of PML occurred, which was back in 2005, roughly. And in their data analysis, they don't see a rebound effect. The problem is the way they did the analysis obscures the effect because they add all the patients. So they look at patients who've been on drug 3 months or longer, and they average that out. You're averaging all those patients that are out a year or 6 months where this effect is gone to them, and so you lose the signal. If you actually analyze the risk that a patient would have more lesions on the MRI at month 3 than they had at their baseline before they started Tysabri, and ask, is that different between patients on drug versus off drug, then you'll see the treatment effect. So my personal opinion is Biogen has not been as forthcoming as they should have been in this issue, and I think it puts patients at risk. We've contacted the FDA. I've been to Boston and talked to Biogen. So basically, this is where patients and physicians will have to collaborate, publish more papers, and eventually confirm whether it's a real phenomenon or whether I'm crazy. But most of my colleagues feel the same way, so I'm not alone.